Go ahead and get started. We've got a pretty steady flow of people coming in, which is so exciting to see. So thank you everyone for being here. I'm going to give it just another minute or so, and then we can go ahead and get started. For our working group members, as always, we would ask for you to put your name and affiliation in the chat so that we can record your attendance. And we have a slide for it as well, where we'll remind you again. Okay, awesome. We've got a pretty big agenda today, so we can go ahead and get started. Welcome, everyone. Thank you for joining us this afternoon. We appreciate you taking time out of your Thursday to be here. So with that, let's get started. Here's our agenda for today. We have a new segment that we're introducing called our Newsy Notes. This is where we're going to be providing you with brief updates or announcements in case folks are not able to stay until the end of the meeting. For everyone who is joining us, please make sure that you're on mute. If you want to come and have your camera up, we'd love to be able to see you. And if not, that's totally okay. As part of our agenda today, we're going to be hearing from our independent reviewer, Dr. Kelly English, about her recent site visit to Nevada. We're covering a benefits spotlight on care coordination with a brief presentation and an opportunity for discussion. And then we're also going to hear about the embarkment of a recent research project on developing a center of excellence for children's behavioral health. So we're excited to share that with you. As always, we do have an opportunity for public comment at the end of this meeting. So if you are not a working group member, we would love to hear your thoughts during that public comment period. For our working group representatives, we would ask that you please add your name and affiliation or organization into our Teams chat so that we can keep track of who is attending. And then we'll go on to our Newsy Notes. So in today's Newsy Notes, we have 3 topics to cover. We'll start with the first note, and I will turn the meeting over to Anne for an update on our specialized delivery system.
Thank you, Carissa. Before we dive in, I just want to first say hello. I was unfortunately traveling on our rural hospital tour during our last meeting, and so it's been a couple months since I've seen this group, and I've been really looking forward to spending this afternoon with you all. I want to welcome and thank our new members that are part of this group more formally. We're really grateful for your time and energy. I know this is taking time out of very busy days and lives, and I'm grateful for your willingness to really support us and guide us as we move through this transformation. So I'm excited to share an update today on our specialized delivery system. We sent an update yesterday afternoon on this. So for folks that may not have read that yet, I do want to share that we are going to be pursuing a new model for our delivery system that will support kids in foster care and kids in our focus population. So before I dive in, I recognize even saying the word delivery system is a little bit of our Medicaid speak. So I want to decode that. Really what that means is whose name is on your insurance card and who is actively contracting with providers, paying claims, and supporting the overall system and network. So initially, as folks know here, we embarked on the procurement of a specialty managed care plan that would have been a single plan that was fully integrated, meaning covering medical, behavioral health, transportation, and other services for kids that fall into this population. We first submitted a procurement in fall of 2025. We then issued a second procurement, another version of that in February of this year with a little bit of a staged geographic scope. But after both of these procurements, we have made the decision to move forward with a different type of model. We did not receive the bids that we had hoped for in terms of developing a successful model, and feel that truly the landscape of our healthcare system is perhaps different than it was when we first embarked on this. And we really want to design a solution that will fit what our kids and families in our state actually needs. So what I'm excited to share more today is a very high-level summary of where we're headed. And what I hope folks really hear is, while the way that we contract and finance this model may look a little bit different, the fundamental building blocks of enhanced benefits and care coordination are remaining the same. And so that means the look and feel to kids and families shouldn't be all that different. It's the way that the state goes about contracting and working with partners to develop this provider network and run it long term will be a new and revised approach. So this decision has been made in close partnership with our independent reviewer and the Department of Justice team. And so we'll be moving forward not with a risk-based single managed care entity, but rather with a new delivery system that will reflect both some old aspects and some new ones. So Carissa, if you move to the next slide, I'll share a little bit more about what's changing and what's not. So again, like I mentioned, we will not be procuring that single managed care plan, and instead we'll be pursuing this new model. We don't have a name for it quite yet, in part because it's a little bit of a blend of a couple of different federal authorities, and there's some complexity in that I really want to spend some time working through and getting feedback on in a subsequent meeting. So I'm just going to use the term specialty delivery entity for now, and we'll work on some more creative branding moving forward. As I mentioned, youth will stay in their existing fee-for-service or managed care plan for their comprehensive Medicaid benefits. So their whole health coverage won't be fully transitioning to a new plan. Instead, they'll stay in that plan, and if they're clinically eligible for this program, they would be enrolled in addition to those services. So that specialty delivery entity would include things like additional behavioral health benefits, like respite care and employment support, as well as that robust care coordination model that I'm excited to spend some more time talking about and getting your feedback on today. That really looks and feels similar to what that specialty plan did. But rather than the medical component of that care being delivered by the same entity, it would be part of the managed care entity. So that requires very close collaboration between our fee-for-service system, our managed care organizations, and this new specialty entity as well. Honestly, while of course we put a lot of time and energy into those first procurements, I'm feeling really excited about what's next and what this means. We get a chance to be creative and designing something that really will work for Nevada and is perhaps a little bit different of a flavor than what other states have embarked on. Although there are a number of states that have pursued a model kind of like this that we're learning from, and I'm having a lot of very direct conversations with their leadership right now, which has been very helpful. So we will share more details on this new delivery system later this summer, and we want to hear your input on that as we really pull together this plan. I'll also note, we recognize we're building towards a long-term system, and we have kids right now that really need support and are not being as supported by this overall system as I know any of us would like. So something that we've done over the past few months is secure new resources from the Nevada legislature to be able to continue to strengthen what is called our specialized care coordination team. These are excellent social workers and nurses and other support staff that work within our district offices in Las Vegas and in Reno to support kids across our full state that need access to behavioral health services and may be engaged in a range of different systems in our state. If a child is part of our fee-for-service program, they are that primary kind of case manager and care coordinator there, and they work closely with anyone else who's involved in that child's care. If a child is part of our managed care program, they work very closely with our managed care teams that have similar specialty care coordinators that are really focused on this type of population and youth. So know that we're continuing to strengthen both for the here and now and also in the long term, and are working to really support our providers that have been working to build towards this model as well through this full transition. So a lot more to come on that front, but wanted you to hear from me about this change, as I know it's a significant one. And for you also to hear my excitement and appreciation for all those that have worked with us so far and helped us really understand how best to do something that's right for Nevada. In this case, slowing down ever so slightly just to be able to speed up and build something correctly, I think will make a world of difference. And I'm really excited to do that. So with that, Carissa, I'll turn it back to you. I know we have a full agenda, so we'll keep moving, but if there's questions that you may have, please feel free to drop those in the chat or send those to our email and we'll be happy to take a look. So thank you for the time.
Thank you so much, Anne. And especially thank you for breaking down some of that Medicaid lingo. I think every time you talk about Medicaid, it always helps me understand better. So I'm sure that many people here are feeling the same way. As Anne said, we will have opportunities for additional community input and engagement on the delivery care system at a few upcoming public meetings and workshops. So now I'm going to turn the meeting over to Dr. Pebbles to tell us about the next steps in our progress for selecting the behavioral health screening and assessment toolkits.
So hopefully everyone's able to hear me. I'm having a difficult time, so I apologize. On my side, it's a little wonky, so hopefully this will work on your side and you're able to hear me uninterrupted. So briefly, we have something coming up. We're going to discuss the clinical assessment tool. We had gone over the screening tools in the past, and thank you to all those who attended that summit. I greatly appreciate your time. And so we did that screening tool summit. We selected a set of tools, and that is to detect any kind of illness. So that's the first level of care. And then the second level of care is choosing a clinical assessment tool. So I know all these words sound relatively similar. That clinical assessment tool are items or tools that are currently in use, ones like the CASI, which a lot of people do utilize for the pediatric population, the CANS, Locust, and then there are additional tools. This is used to determine the level of care needed or so whether that child is best served in an outpatient setting, if they're served in a PHP IOP program, if they need acute hospitalization, or if they need residential care. That's the point of this particular tool, is to determine what level of care is appropriate so we can ensure that these kids are staying within their families and within their homes when possible. And so we'll have an upcoming summit about that, and we'll discuss that further. That last level of screening is a comprehensive assessment. That is an assessment that's completed by a QMHP, so a qualified mental health professional, like a therapist, a physician, a nurse practitioner with psychiatric specialty like myself, or a physician with a psychiatric specialty. That's just basically what everyone does day to day. If you work within mental health, that's where we compile histories, we determine diagnoses, and we come up with a treatment plan. So just again, as a brief reminder, we have those 3 levels of care. We've gone over the first one and chosen the set of tools for that to detect early illness. This second level is what we're going to be concentrating on shortly with the Clinical Assessment Tool Summit. And so next slide, please. So this is the Clinical Assessment Tool Summit. Some of you have received an email if you have signed up for the behavior. You received an email this week with some surveys, one of which asked for what day and works best for you. That will close tomorrow at 5 p.m. I'll surely be able to tell you on Monday, likely, what day we're going to choose for that summit. This summit will be shorter in length than our screening tool summit, approximately 60 minutes. Likely virtual, but again, we'll be able to tell you that date and time soon. So we'll be able to give you a link as well. But if you have received the survey, please feel free to fill that out. Again, it asks your availability, but also gives you an opportunity to vote on what clinical assessment tool you would prefer to utilize. And so again, like I had said before, we chose that set of screening tools already in May, and we're in June currently. So we're going to be initiating that summit to discuss the clinical assessment tools, what your experiences have been, what your concerns might be, and then what the next step in the process is. In July, if for whatever reason you're unable to attend that summit, I'm more than happy to meet with you one-on-one to discuss whatever it is you wish to let me know. We greatly value your feedback and your experience. I can say what I want to say as a provider, but I really want to hear what you want to say and what your experience is. And so in July, don't worry if I'm not able to get to you or you're not able to get to the summit. I'll be happy to meet with you one-on-one. And then the plan is to go ahead and choose the tool that we're going to utilize and present that in August for approval.
Okay. Thank you so much, Dr. Pebbles. We really appreciate you giving us that update and sharing about the Clinical Assessment Tool Summit. Casey on our team just put in the participation survey so that you can all fill that out, and we would love to get your feedback on what day and time will work best. Our next update is about some ad hoc CBHT working group sub-meetings. I know that's a long way to explain what these are, but essentially as part of our shift to these bi-monthly public meetings for the CBHT working group, we've started offering some opportunities for closed ad hoc discussions with working group representatives. These discussions allow us to really dive into the nuance of various topics that we're interested in learning about your perspective and that you have shared wanting to talk a little bit more about. So in May, our meeting was focused on the front door, which was essentially how youth are entering psychiatric residential treatment facilities, or PRTFs. And we are currently finalizing some of the feedback that we heard from that meeting, and we'll be able to share that out with you soon. In July, we plan to bring a similar conversation to working group representatives that really focuses on the back door of how a youth is exiting from a PRTF. So that's really how are we creating meaningful discharge plans and plans of care that support the youth with transitioning back to their home and with finding the appropriate level of community-based care. So the other ad hoc meeting that we are planning is going to be a listening session about the Center of Excellence, which we're going to be talking a little bit more about during that section of today's agenda. To the comment in our chat, yes, these slides are going to be posted on our website. And then for some of the other questions that we have, we will be reaching out to you either directly or in when we have those opportunities, such as during the Clinical Assessment Tool Summit, we can talk about that question. And then, and I see you answering as well, so thank you for doing that. So next up, we are going to go into a conversation with our Nevada independent reviewer from the DOJ settlements, Dr. Kelly English, who is going to share her perspective from her site visit to Nevada back in late April and early May. So Kelly, I will turn it over to you.
Good evening, everybody. Happy to be with you all tonight. I'm joining you all. It's a little later here on the East Coast where I'm located. So hopefully I won't nod off in the middle of this. I tried to drink an extra cup of coffee tonight. So I am here to share a little bit about some of the, as Carissa mentioned, some of the findings from my on-site visit to Nevada, which took place kind of last week in March, early April. So next slide, please. I thought it was worth just backing up a little bit to share a little bit about the role of the independent reviewer. So I don't work for the Department of Justice. My job is to kind of make sure that the agreed upon terms that were negotiated between the state of Nevada and the Department of Justice are being complied with. And so how does our team, I have a couple other folks who work with me at the UConn Innovations Institute who assist in doing some of that. So part of our how we go about monitoring, We look at a lot of documents and data. There's a quarterly data report that we receive. So we take a look at that to get a sense of progress with respect to serving children. There's a lot of documents and materials we'll review, whether that be the state plan amendments or the Medicaid services manuals or other presentations or reports that are publicly available or have been sent to us by the folks at the state. So there's kind of a paper review. We've also done stakeholder interviews and meetings with various folks from across the state, including some of you who are on this call this evening. We also, and this is part of what we did when I was on site, was to go through and tour facilities, meet with providers, chat with families and other stakeholders, and meet with folks from the state to get a sense of their progress. We are also engaged in a pilot right now of something called the Quality Service Review, which is a kind of rigorous approach to looking at quality by getting a random sample of youth and reviewing their records, and then also talking with providers who are working with and the families and youth as well. I think my colleague Elizabeth Reno was here at an earlier work group meeting and shared a little bit about that quality service review, so I won't go into it in detail tonight. The independent reviewer also has joint meetings on a regular basis between the parties to discuss progress and any challenges or barriers to implementation of the agreement. Next slide, please. So with the agreement, the independent reviewer is required to post compliance reports. You can see some of the dates. We have one coming up quite soon. That is due July 1st. And then our next report, there was a baseline compliance report that was issued in October. The first full compliance report is due in a couple of weeks. Then we'll have another compliance report due July 1st, and then one needs to be issued every 6 months thereafter. And in those compliance reports, you'll see we have to rate the state with respect to their progress on compliance on a number of on each item contained within the agreement. There's about over 100 items that are contained within the agreement, and the state gets a rating on all of those items. The ratings are specified in the agreement, so it's either a non-compliant, partially compliant, fully compliant, or substantially compliant rating. And those reports talk about kind of where the state is in terms of the compliance, any recommendations that we think are necessary to kind of support compliance. And that upcoming report will be posted on the state's website once it's been finalized. That report gets sent to the state and to the Department of Justice. Both parties review, offer comments, and the report is revised based on those comments. Next slide, please. So as part of the compliance monitoring work, I did a site visit out at end of March, early April. This initial site visit focused, I spent some time in Carson City and Reno and Las Vegas. A future site visit is in the works to do kind of a northern rural tour sometime in the fall. So that's coming. So I'll be working with those of you and on this call and the state team to really figure out what are the best locations and providers and other stakeholders to chat with while I'm there on site. So while I was there on site, I met with a number of state and county officials. Again, some of you on this call met with some service providers. We did a stakeholder meeting in Las Vegas with the assistance of the Nevada PEP team. So grateful to them for their assistance in pulling together an in-person meeting with families and a variety of other folks to hear their perspectives, particular to mobile crisis response. And then we spent some time just touring facilities. So some inpatient psychiatric hospitals, some PRTFs. We saw some specialized foster group homes, juvenile detention, and I visited Child Haven in Las Vegas while I was there as well. All right, next slide, please. So this is, you'll see that the compliance report is going to get posted and finalized. And for those of you who are really curious about the independent reviewers assessment of where things are to date, you'll be able to see that soon. But you know, just as far as some of the big picture progress and challenges at a really, really high level, it gets a lot more granular, as I mentioned, because there's those ratings on the 111 items in that report. But, you know, generally, areas of progress that kind of I noted as far as the implementation of the agreement, you know, I have to applaud this team at the Nevada Health Authority and the state for their work on really having what I perceive to be a pretty solid stakeholder engagement process. This meeting is evidence of that in my mind, bringing together a group of folks from across the state and posting meeting materials publicly. The state has I think, done a good job of trying to really engage as many people as possible and have a transparent process to share with folks about what is happening in a public way. I know the state also has hearings, public hearings, and other public forums for, you know, the state plan amendments and those kinds of things that are also happening as well. And I know they've done a lot of work to update and improve their website to ensure that materials are publicly available. You know, as you've heard Anne describe during some of these meetings, I think there's been good work on some of the very technical components that are necessary in order to pull off this transformation effort and implement fully the agreement. So there's been the state has worked hard and is continuing to work hard to obtain federal approval and has indeed obtained federal approval for some of the services in the agreement. Family and youth peer support is a good example of that. And I know they're continuing to work on that. They've been making changes to their Medicaid services manual and have been working to make rate changes to align incentives for providers to deliver these services. As Anne mentioned at the top, there was a lot of work put into the specialty managed care plan procurement, so I want to give them credit for all of the time, effort, energy, and work. It's not easy to pull off a state procurement. As a former state official, I understand how much work and energy, time, and effort goes into that. I know that ultimately there wasn't a successful, it didn't result in a successful vendor being selected. And so they're going to go back to the table on that one. But it indeed, you know, did occur. And so I know they're engaged in the effort to continue to refine what the delivery system mechanism is going to be. The state's also done a lot of work on data and analytics infrastructure. There's a quarterly report and a public dashboard that I know that was mentioned at one of these past meetings. So that's really critical. Without data, we won't be able to really tell, are kids actually indeed getting some of these services? How many kids are still in out-of-state PRTFs, for example, are things that we're going to be looking at. So I think that's really critical. On the family peer support certification process, I know that getting that stood up in my state where I live was really still is a work in progress. So I was impressed that with the work that Nevada PEP and has been doing to get that certification process moving along, and I understand there's been really good forward movement on that with the Nevada Certification Board. So happy to have seen that happening. As far as challenges, I think one of the things that I'm paying attention to in these early years of the implementation is that it's critical that the screening and assessment procedures that the state develops are identifying the children accurately in the focus population. And so, until those screening and assessment procedures are fully implemented, there's still going to be a risk of under-identifying kids who are part of the focus population. That's one way. Until mobile crisis, for example, is up and running fully, there's still going to be, and there's good data on that, there's still going to be risk of under-identifying kids as part of the focus population. And once you're part of the focus population, just who is eligible for the focus population is really clearly spelled out in the agreement. That kind of unlocks some of the access to some of these specialized services that are contained within the agreement. So I think that's something I've been paying attention to, is making sure that the state is accurately identifying those kids for the focus population. I think there's still quite a bit of continued reliance on out-of-state institutional settings. This is a concern, I think, as many of you know. I mean, the farther kids are away from their homes and communities, the harder it is to get them back into the state and get them back to school, back to family. And it's also hard to monitor quality of care that are being provided in out-of-state facilities where the state doesn't have the same kind of licensing authority and that type of thing. So I think that's something else that's going to be a continued challenge and something we're paying a lot of attention to. I don't need to tell you all about the challenge that exists with really ensuring access for your rural and frontier communities. Also something we're trying to pay attention to. We also noted that there's service gaps, for kids with co-occurring behavioral health needs and intellectual disabilities and autism spectrum disorder. There is a slightly higher percentage of kids who are in the focus population as identified, at the moment, who have a co-occurring behavioral health need. And I think making sure that there's adequate services for those kids is going to be a really, really important and a critical piece of this work. I think the workforce, I heard a lot about workforce and provider capacity constraints, having enough people and enough humans to actually staff all of these programs, staff mobile crisis teams, build up these new care management entities, and particularly in rural and frontier areas, is going to be a continued challenge. And I think the development of kind of the crisis system infrastructure and making sure that there's really clear pathways to access those higher levels of care, and revised authorization processes for higher levels of care, I think, are still things that are in flight, and are still a challenge at this moment in time. So I'll pause there. I don't know. I want to do a time check to see with Carissa about where we are on time, and this question that I had there about what this group might add as far as progress or challenges.
Yeah, thank you so much, Kelly. This has been really informative, and you've been really helpful in this whole process. And so I think time-wise, we're right on the time where we'd probably want to be transitioning, but at the same time, we do still want to hear folks' feedback. So if you do have any additional thoughts on the progress or challenges, we would ask for you to include that in the chat, and then we will be sending that out in minutes following this meeting. And then also, just as a reminder, this is not going to be Kelly's only time visiting Nevada. She is going to be coming back in the fall, where she will be able to visit some of our rural communities, and we can talk about that a little bit more in the coming months. And then, Karen, to your question in the chat, yes, these compliance reports will be posted online to our Children's Behavioral Health website. So with that, Kelly, I just want to ask, we can see what your next slide is, and then maybe if you have any concluding thoughts, we would love to hear those. Oh.
Yeah, that was it. I think that
Perfect.
was the so happy to, if folks have questions or other things they want to put into the chat. But yes, I plan to be back in the state, and also, we'll be doing some meetings virtually with folks as well. So it's not the only way you'll be able to see me is when I'm there in person. Obviously, I attend these meetings regularly and have been reaching out to people, virtually as well. So look forward to, seeing more of all of you and learning more about the progress with respect to the implementation of the agreement.
Okay, wonderful. Thank you so much, Kelly. If we do have any time at the end of this meeting, we can reach out or we can come back to some of these questions that we're getting. I do just want to say congrats to Karen and Nevada PEP. She put an update in our chat that the Family Peer Support Training Endorsement and Nevada certification are up and running. So yay, that's so exciting to hear, and really great job on all the work that you did in that on that front. And to Kelly, thank you so much for being here with us tonight. We know that you did have a prior obligation, so we're excited that we get to have you join us now. So thank you for sharing those updates and some of what you observed in Nevada. Up next, we are going to go into a spotlight on the care coordination benefit. We have had a few ongoing discussions around this topic, so we're excited to continue that dialogue today. So Matt, I believe I'm turning it over to you to get this ball rolling.
Yeah, thanks so much, Carissa. Hi, everyone. Matt Burdick, consultant with Nevada Medicaid. Great to see so many familiar faces. I'm going to move relatively quickly through this because I want to make sure that we get to the meat of this topic, which is really the discussion portion. But since it has been, I think, close to a year since we last talked about this, wanted to re-ground us in some of the basics here. So the DOJ settlement really does set out a vision for care coordination. And as we've been talking about and really thinking deeply about all of the challenges that we face, care coordination is really at the center of how we're going to effectuate a new system that works for families. And so we're really trying to take a really thoughtful approach to how do we really bring a more robust set of care coordination services to ensure that kids and youth can really get the services that they need. And while we're legally obligated to establish this new thing, we're also trying to think really carefully about where does it fit into the broader world. There's a lot of coordinating of care, managing case management. We have all million different ways to talk about this thing happening all throughout our system. So how do we make sure that we're not just adding a new component to the puzzle and actually making sure this is something that's more integrated into the system as a whole? And really the goal here is to have something that's a little bit more structured, evidence-based, and so that families can really understand what they're getting when they're getting care coordination, and that we have care coordination that is really actively driving the care, not just sort of triaging or maybe giving kind of, list of phone numbers, et cetera. Really an active case management or care coordination system that requires an investment to be able to make possible. So we'll talk about what that looks like. Next slide, please. So why go this route? Well, there's a couple different reasons, and this is really rooted in what I think bore out in the settlement of where other states have seen success. We know that there are actually evidence-based ways of doing care coordination. And we know that that can really make a difference when you're doing something that has shown to be working. We're figuring out a new infrastructure, and so as part of this broader delivery system change that Anne talked about, we still intend to use these care management entities to really be the backbone of our care coordination work, having organizations that are really focused on the needs of this population and on the work of doing care coordination. And what's really unique about the models that we're building is the idea of having a facilitator. It's less about having a person that knows where everything is in the system, and also about someone that knows how to work with families, knows how to meet them where they're at, and help them draw on their experience to define what they truly want and need, and then also make that warm handoff and make those connections to other points in the system. So really trying to really center that family voice more in how this work looks and feels. Next slide, thank you. As we've talked about over and over again, we've got some kind of definition around who is eligible for these things. And so we have the behavioral health disability, which then leads into our focus population. We're still having conversations about how broadly to cast our eligibility for the service. That'll be one of the things that we'll need feedback on ongoing. As with everything, we are really struggling with the broad needs out there and the limited workforce. And we are bound by the settlement to focus on our, as it's called, focus population. And so we at very least need to make sure that we have sufficient infrastructure in place to meet the needs of that group of kids, but we want this to be available to a broader set of kids who can need it. Just a matter of when and how we can make that happen. This is a slide that should look familiar to people, but it's got a little bit of a refresh to it. Really delineating between two different types of care management that we expect will be happening inside of this whole ecosystem. The first, kind of the top of that inverted pyramid there, that's the model that I've been talking about and that we'll really spend the bulk of our time talking about today. These are two flavors of really more intensive care management that we'll talk about in a second here, and really focused on those kids that have the highest needs. This is also where the settlement binds us to say that we actually have to offer all youth and families access to first the most intensive model and then a less intensive model of this, where they can then opt out. We also want to make sure that we're not leaving any of our youth behind. And so how can we also embed some of the kind of generalized care coordination, some of the things you might get from a managed care organization or other targeted case management services to support youth and families who may not otherwise have access to those, or may need some additional support in addition to supports they already have in place. And so we're also thinking about not leaving any youth behind, even if they're not eligible for or wanting to access that more intensive level of care coordination. So this is a little bit more fleshing out kind of how those tiers, as I referred to them, play out. The first tier is what I was just talking about. That's that generalized care coordination that is a little bit lighter touch, but still really kind of keeping an eye on the holistic needs of a family. 2 and 3 are really two sides of the same coin. The third tier on the far right there, this is what you typically think about as high fidelity wraparound. This is the model that's the most intensive. It's also the most prescriptive. And that's why the settlement agreement has this second tier. The settlement agreement calls it intensive care coordination, which gets a little confusing. Because that can be also sometimes how we refer to tier 3. So we're thinking about calling this enhanced care coordination. It's not really that high frequency, high touch, but it has a lot of the same elements. But it might have some flexibility in terms of How frequently do you meet? Do you meet in person or do you meet virtually? Just trying to make sure that for families where that high intensity may not be a good fit, they still have access to something that's a little bit more robust than what they typically get from a care management and a case management system. Next slide, thank you. Not going to spend a ton of time on this, but just trying to break down for folks kind of how these different flavors of case management will look, or care coordination will look across different pieces. Go to the next slide. And then this again kind of spells that out. I'm not going to dwell on this because I do want to get to this conversation portion, but these will be in with the slides, and encourage folks to take a look at this as they have time. And just a little bit about kind of how does this process work. And this is really specific to those higher tiers of care coordination that we're talking about. But really at the core of it is what's known as this child and family team. And that is the youth, their family or caregivers, and other people that that youth and family identify as key to their success. There's the facilitator, who is kind of like the quarterback of the child and family team. They're the one helping to call the plays, make sure everyone's where they need to be. And I think of the family almost like the coach. They're the one setting the agenda, and it's the final say, but you got to have someone that's really getting it done on the ground. And so that's what that role, that facilitator, does. And together, they create a care plan. And that care plan both serves as the foundation and the roadmap for what services that family needs, as well as sort of the authorizing point to access some services that aren't available to all the youth. And so this is sort of that funnel of we plan, we make some needs, and then they can also provide something tangible in an enhanced set of benefits. And so those, we're really looking at 3 core services in addition to all the other services of this child and family may need and have access to, but these are the ones that are sort of driven through this process. The first is intensive in-home treatment, and we're still in the design phase of this here in Nevada Medicaid, but recognizing that this is a model that's worked in some pockets here in Nevada, and we want to bring that into the fold of our broader Medicaid ecosystem and really leveraging the use of specific evidence-based practices that have shown to be effective with youth and families, and make sure that those services can go to where the youth and family are and meet them where they're needed. Throughout all the conversations we've been having with other states, flex funds comes up constantly. One of the biggest barriers for families might be a need completely unrelated to their mental health or their healthcare needs. It could be paying a light bill that month, or needing to do some other activity that's not really a healthcare service, but would make a ton of difference in the health of the family. And so how can we use this process to authorize some of those things to help with those small challenges that become catastrophic challenges if left unaddressed? And then respite care. Again, this is something that'll be new to the Medicaid system and that we're working to design, but really having these be some of the core things that are uniquely offered through this pathway. And again, other services and supports the family need would also be facilitated by this process, just not authorized in the same way. Next slide, please. This is more context for the conversation I believe we're having next time or next month that Carissa mentioned. And this is really about one of the unique roles the child and family team will play is when a child has been placed at a PRTF. The child and family team is going to have some of a privileged role in facilitating what that child needs and helping that child to successfully discharge. And so that's where the conversation that's going to be coming up at a future meeting is really going to focus in on, is how that's going to work. That's going to require some culture change on the part of our PRTF programs, on the some change of thinking of us at the state, as well as a different experience for families that are navigating this level of care. And so we need to really be intentional about that. But we are driven to do something different by the settlement, and so this gives a little bit of background on what that looks like. So we're not going to get into the weeds on all of this today, but this just gives you a little bit of a menu of all the open questions that we are kind of wrestling with. So under that first bucket of reimbursable activities, that's pretty well set in stone, and we'll be coming to you in a future meeting with kind of a blueprint, a policy print of how this looks. But sort of the things that this will be happening in the context of this care coordination that will be paid for. Some decision points that we will need to bring back to this group are timeliness standards. That means from the time you're referred, how quickly do you get access to this care coordination system, as well as when you have identified need for a service, how quickly should you expect to be able to start with that service? That's going to be a really key piece. Frequency of contact is really key. We want this to be a high touch, high frequency service. The challenge is that not every family wants to be met with as frequently as maybe the model would demand. So how do we balance what's right for the family, as well as not losing momentum when we need to make progress? And then staff to client ratios, recognizing for the more intensive models, we really want a smaller staff to client ratio and have to balance workforce challenges. In terms of reimbursement, we are really thinking that a monthly rate will be what's most appropriate, and looking across different states, that's really been sustainable, provides a lot of flexibility, and so you're not necessarily focusing on each minute activity, but you're working on the overall progress and work that's happening. And we recognize this is just going to be a really difficult system to stand up in our rural areas. And so how do we incentivize providers to actually participate there? But again, the goal is to really take our time with this. We'll have more details in coming meetings about some kind of transition planning, how we're working to build out some network of providers and get providers ready to work in the Medicaid space. That's one of the key barriers we've identified through all of these processes, is that Medicaid is really difficult, and it doesn't make life easier for people that want to actually serve kids on Medicaid. So how can we help providers that want to get into this business come along and be ready for that once this all launches in this kind of new arrangement that Anne described at the top? But I'm going to stop talking. I'm going to turn it over to Anne to get to the important part of this agenda, which is really facilitating some discussion.
Oh, thank you, Matt. That was an incredibly thorough and clear discussion of something I know has been a really important topic for this group over time. And I love seeing how it continues to evolve and the ways that we can continue to get your feedback to make this model really work. So before we dive in, I will always look to my guide through this work. Carissa, can you keep us honest on the timeline here? I just want to make sure we have a great presentation coming up on our Center of Excellence. And so I want to make sure we have time for that too. So help me understand the kind of time frame here, and I can tee up our discussion from there.
Yeah, I think we can spend about 10 minutes on this discussion portion.
Wonderful. So welcome questions, comments, feedback on this now in these next 10 minutes. And then of course, as always, through our email, if things come to you later if we can't get to each of the items. But really want to focus our discussion today on that child and family team. We recognize each of you are coming to this discussion from a somewhat different perspective, whether as a family member or caregiver, as a provider, from our child welfare system, or as a foster family as well. And we really want to better understand, how do you really want to be part of this work? What is useful to you? Not care coordination for the sake of it, but really coordinating a conversation that feels action-oriented and focused on actually getting access to services and following progress towards a treatment plan that's really aligned with what our youth and families are looking for. So our questions here I'll read for folks that may be joining us by phone. From the family perspective, we would love to hear what supports, information, or conditions would help your family be able and ready to participate in a child and family team. That includes some of the logistic things that we know make a big difference. Is it in person? Is it virtual? Is it in the evenings or on a weekend or during the school day to incorporate the school teams, right? We want to hear what flexibility is most useful to allow you to really participate in a way that feels meaningful. From providers, we'd love to hear what makes it more feasible for you to participate. We know there's a host of things on your plate, and this is yet another, and it's a really important one. So how can we make it easier for providers to be part of this important conversation? From the child welfare perspective, we recognize the way that care coordination works for kids that are engaged in our foster care system often looks and feels a little bit different because there's already some really important child welfare targeted case management that's happening. And so how do we really incorporate those two worlds? We've been doing a lot of thinking and conversation with our partners on really developing those swim lanes or collaborative partnership. We also recognize foster families have a different experience of these child and family teams at times, and we want to better understand what unique support may help really engage you in that process. So I'll pause there and welcome feedback in the chat. Feel free to raise your hand, come off mute, and chime in. We'd love to hear from you. Yeah, Jessica, nice to see you.
Hi, everybody. My name is Jessica Goguchia, and I am the coordinator over all of clinical services and mobile crisis for Washoe County. And I just want to say, previous to my position now, I was a provider, a Medicaid provider. And one of the things, as from the provider perspective, is child and family team meetings are not paid for the providers who are not the case managers. So when you are actually serving the Medicaid population and you really are involved in targeted case management, or the WIN program, which is wonderful and amazing, and you have 15 kids who have family team meetings, and that can be between 15 and 20 hours of child and family team meetings that you want to participate in. But when you're a billable person and those are not billable, that makes it very, very difficult. And at some points, we had to make decisions on whether we kept an agency moving and salvageable for billing purposes, or we showed up to team meetings. So sometimes it's, I can give you an email update and it's not the same. And so I think that that's something that's really important to think about, is how to ensure that some part of that can be feasible for providers, especially providers in private practice that don't have agency backing. And then just quickly from the child welfare perspective, I think that, you and I have talked in lots of different meetings about those swim lanes. And because of the team meetings that also have to happen as part of the child welfare process, finding the right way to make those into a comprehensive meeting. I don't know the exact answer to that, because I know there have been different models that have been attempted and tried. And sometimes, the meetings need to happen after hours. And so I don't know the answer, but I think that really determining how to meet the needs of both agencies, the agency that's providing the case management and then the child welfare agency, is going to be important. And I also oversee our specialized foster homes, and we do have a really hard time, especially those homes that have a lot of kids, because they have their own kids and adopted kids, and then they have the youth who are living with them. All of those things really do play into, can they be on a meeting for an hour? Can they be in person somewhere for an hour? Who's going to care for their other children when they are doing that? So that's the foster family piece that comes up a lot when we have that expectation of them to be at these meetings. That's all.
I really appreciate both those angles, and as always, all the angles that you bring to these conversations. So thank you. Absolutely echo. I know you got a lot of reactions in the chat on the billable component. That is something we've heard loud and clear, and it makes a ton of sense, right? We live within a fee-for-service world, and that billable model really does drive what access is possible and what services are possible. So this is something that I know our team has been actually looking really closely at, from how other states have done this, and how can we find ways to maybe even get federal approval to be able to support with that. So we don't have an answer for that yet, but definitely a top priority for us to figure out, and helpful to know how much that could unlock an ability to participate in those meetings. So thank you for that. And from the child welfare perspective, very helpful as well. And I look forward to many more conversations on it, but hopefully really getting to that nitty gritty of what is those swim lanes. So thank you for that feedback as well. Yeah, Carly, nice to see you.
Hi, thanks, Anne. I first of all just wanted to say thank you guys so much for your thoughtful consideration of this. I can definitely already hear a lot of the things that came out of that Care Coordination Summit and what Matt presented. So I really appreciate that. Thank you. As far as the family perspective, I think it's really important that we set the ground rule and the expectation with the entire team right from the start that the family is really driving the services. And that the family gets to determine the time and the location that works best for them for the meetings, as well as, what services fit the needs of their family the best. Thank you.
I really appreciate that. And yes, to Carly's point, we had a really great summit that was specific to kind of youth and family voices on what should care coordination look and feel like, really to inform that specialty plan scope of work. And the great news is that all of that is incredibly relevant to how we move forward here. So thanks for that feedback as well, and your continued input in this process. Any other feedback from the group here? I'm seeing Azraella, nice to see you. Seeing your comment in the chat about, is there an ability for providers to access flex funds? Super creative. I don't know if I've thought about that. My team, they're smarter than me. They probably have, but definitely a great component for us to think through. And Karen, seeing your point to that front as well. And finding that right balance between frequency is going to be really key. So thanks for that input. I appreciate it. All right, Laura, seeing your hand up. Nice to meet you.
Hi, thank you. I would echo what my colleagues have said already about the challenges that get in the way of families being able to participate. One of the things that I think that we don't necessarily give enough attention to is I work for a longer term PRTF for kids who have failed and failed and failed and failed at PRTF in return. And one of the challenges that we see the most is that there's a lot of change that usually happens in there, or there's been a lot of damage to the family system itself. And so making sure that there's sufficient time spent paying attention to the attachment of the family itself so that the attachment can happen in a positive, we use attachment focused family therapy where we're really just spending time being pleasant together and learning to like each other again. And that's not really something that folks want to pay for or see as part of family therapy a lot. I get a lot of pushback for that being a billable hour type of thing. And so making sure that we want to motivate the kids to want to get better. And when it feels like I'm just going to go to someplace I don't want to go, that's one of the biggest reasons that our kids tank. And so, when you have a new foster family that's presenting, making sure that the foster family is appropriately compensated to be able to participate in those things as well, to be able to come out and do new things. Sometimes we may only be allowed to do like 1 or 2 family sessions right before somebody's identified, and then they discharge, and that often ends in disaster. And so really being cautious and careful with that, what that discharge planning should look like, so that it really is supportive and the kid can grow from the place that they've become comfortable, rather than trying to go, okay, I haven't tried to kill myself in a week, you're good. As that sort of level is is often the medical model's view of when the child should discharge, rather than when the supportive care has happened. So I think taking great attention to that, both sides in and out, is going to be really important for us to make sure that there's a good outcome rather than just good outcome while they're here.
No, Laura, thank you for that comment. And first and foremost, thanks for all you're doing on a daily basis. That's the real hard work. And I agree. I think thinking about the holistic family unit throughout treatment, but particularly in those transitions to and from really acute settings is crucial. And while I didn't have the chance to be part of that lunchtime session, I know that was a key topic that other folks had brought up. So we're continuing to think through ways within this model that we can help support providers doing this. And if you have suggestions of ways, I'm all ears, because we agree that's a really crucial component of therapy. So thank you. I appreciate it. I think we'll be able to fit in one more comment here. So Kathleen, seeing your hand up.
Hi there. I'm a BCBA in the state of Nevada, and we're also a Medicaid provider. And I'm also on the board for the Nevada ABA providers in the state. And so I'd love to be able to bring something to our ABA providers of like how we can kind of help be part of the conversation and be kind of like one of those resources for some of the individuals who might have some dual diagnoses for you guys.
Yeah, I appreciate that, Kathleen. So, and saw your question in the chat there, was thinking through, and I wish we had a way for all providers to really get tapped in right now. What we're talking about here is kind of the system we're building towards. So we do not yet have the care management entities established across the full state and up and running with this type of model. Our WIN program is a great example of kind of a more small scale version of this program that we will have statewide as we build through this transformation. So I don't think there's one way or one place for providers to go right now, or your ABA provider community to go to, but I think continuing to partner with providers and organizations across our communities will be key for folks to kind of become aware and remain aware of what services and supports are available, both short-term and long-term. So thank you for that question.
Awesome, thank you.
Yeah. All right, with that, Carissa, I'll turn it back to you. Thank you for the time and input. We again welcome come to our follow-up kind of conversations on the PRTF component. We will have more soon. And we also would love to continue to reflect your feedback in our policy on care coordination. So if thoughts come to you later tonight or any other time, send those to our email address that we'll share at the end because we'd love to hear your feedback. So thank you. And Carissa, I'll turn it back to you.
Awesome. Okay. Thank you so much, Anne, for leading that discussion and for everyone who shared their thoughts in the chat and came off of mute to share with us. That is so important to us. It is really important that we are creating systems that work for everyone involved. And so that's really why your input in these discussions is incredibly helpful and valuable to us. So if you have any additional thoughts or questions that you'd like to share, please reach out to our behavioral health email, which is on our website, or it'll be at the end of these slides as well. So moving on. Oh, and thank you so much to Matt for giving us that presentation information. Y'all have been working really hard on the care coordination pieces, and so we are very grateful that you could talk to us about it tonight. We do have an exciting project to share with you today. So Nevada Medicaid has been working with a vendor called Bowling Business Strategies to conduct research on the development of a center of excellence, which will be focused on the children's behavioral health. So today we have the pleasure of being joined by Dr. Stephanie Woodard and Rachel Faulkner, who are going to walk us through the project overview for the Center of Excellence. So Dr. Woodard and Rachel, I'm going to turn it over to you to take us through the last third of our meeting tonight.
Thank you, Carissa. So as Carissa mentioned, my name is Stephanie Woodard. I am the managing principal at Bowling Business Strategies, and I'm joined with my colleague, Associate Principal Rachel Faulkner. We have partnered with Nevada Medicaid to explore the development and launch of a Children's Behavioral Health Center of Excellence. Next slide. So important to define first, what is a Child, Youth, and Family Center of Excellence? We are benefiting a great deal from some pretty extensive work that has already been accomplished across the country, leveraging a report that was written in 2015 that really collected essential information from existing centers of excellence to better understand who they are, what they do, and how they function. And this guiding document has really been formative in our thinking about how to better define a Children's Center of Excellence for the state of Nevada and gathering additional information that will go into the unique design and implementation of a Center of Excellence here. So what is a Center of Excellence? They often provide that really essential component that is necessary for system transformation and implementation. So they are the ones that provide training and technical assistance and coaching to organizations that are looking to implement evidence-based practices. They really walk alongside organizations and providers to support ongoing practice improvement, quality improvement, and helping them make the most of evidence-based practices with a focus on fidelity to models. They also can assist with doing a number of other functions, including policy development, supporting Nevada Medicaid and others in thinking through what additional services, supports, and evidence-based practices could be of benefit to the state. Next slide. So some core functions that we know are really necessary in practice in system transformation in states and where we have seen other states really succeed in going from sometimes very nascent services like Nevada has for a range of community-based services to getting them to scale and of high quality where they are able to provide really high-level services for children, youth, and families. Core functions include that implementation support of evidence-based practices, promising practices, and service delivery models, as well as providing research evaluation and data linking capabilities, supporting partnership engagement and collaboration. Also, additional workforce development strategies like training and coaching. And then some COEs also provide that policy and financing expertise. So those are really the foundations for successful implementation. And components of a COE that we are taking into consideration and exploring are the design and infrastructure related to governance, staffing. So what kind of staff does a COE need to have based on the evidence-based practices that are selected by the state? And what kinds of functions would those staff hold within the COE? Is there a necessary administrative backbone for business support? Are there funding models that we need to consider? Stakeholder engagement, as well as their responsibilities and support for strategic planning and opportunities for data and technology infrastructure. So what kinds of data and technology infrastructure do they need in order to provide some of these essential core functions? Next slide. So a little bit of our project overview. We are looking to engage at least 3 centers of excellence across the United States that are already focused on children's behavioral health in an effort to gather information from them as to what they have done to first launch. So we're paying very close attention to what is essential for a COE in its design and implementation structure for the first 3 years, so that we can take that into consideration as we're supporting Nevada Medicaid and thinking through what a COE for Nevada could look like. And then we're also looking at what it is that they're currently doing so that we can identify what their growth trajectory has looked like and how they've gotten from where they started to where they are now. So Nevada can take that into consideration as they continue to pursue a center of excellence. So we're gathering a whole range of information from them to aid in our consultation process. We're also conducting stakeholder engagement and outreach. We have identified state agencies that may have a vested interest in knowing more and giving shape to the Center of Excellence. We're also talking to higher education, this group, and I will mention opportunities in the future for us to also engage this group in additional information gathering, community partners and providers, as well as managed care entities, to really understand what are the current realities on the ground related to capabilities and capacities for existing entities to potentially grow into a center of excellence. Are there preferences for the design of the Center of Excellence? And where are there opportunities for collaboration? And how do we reduce potential risks for duplication of efforts? And then drafting an initial design and scope of work for the first year of the Children's Center of Excellence, recognizing that it will take time for the Center of Excellence to develop fully and get launched. So that 1 to 3 year period is really a critical period for Centers of Excellence. And we want to make sure that we are supporting Nevada Medicaid in developing the most realistic design for a Nevada COE. And so we'll be thinking through a number of different components along with all of those essential core elements of a COE to help to figure out where do we begin and what we can realistically project into the future for Center of Excellence development. Next slide. So again, stakeholder engagement, we're working very closely with the Nevada Medicaid team. They are working with us to help to define what is the vision and structure and function of the COE. We're also doing a lot of stakeholder engagement, looking to also find ways to engage in semi-structured interviews and focus groups to gather additional information. And then we're working closely with the independent reviewer, Kelly English, who you already heard about from this afternoon, looking at additional input related to how do we ensure that the Center of Excellence design and implementation strategies really do take into account some of the requirements for the settlement agreement so that we're working kind of lockstep with one another. Next slide. The centers of excellence that we will be engaging include Case Western University Center of Excellence, University of Connecticut Innovations Institute, UC Davis, as well as we are reaching out to Ohio and others, trying to gather as much information as we can so that we can learn from others' experience and use that information in designing the Center of Excellence for Nevada. So gathering information again across a broad range of issues so that we can better understand what is necessary to give lift to a Center of Excellence here. Next slide. So some key decision points that we are already forecasting that we will be bringing to stakeholders as we engage and working through with Nevada Medicaid include the organizational home. So will the Center of Excellence be within a state agency, or is it possible for it to be in a university, academic institution, or a nonprofit? There are arguments to be made in a lot of different directions, but we do see the majority of centers of excellence residing within academic institutions. Also determining what are some of the initial evidence-based practices that the Center of Excellence will be able to support in making sure that providers have what it is that they need by way of training, technical assistance, and coaching so that they can be successful in that initial implementation and then sustaining high quality implementation and fidelity into the future. Also thinking through what is the initial scope that's most appropriate for the Center of Excellence and what are the directions in which they should be planning to grow in those first few years of operation. Thinking through what information do we have, including a statewide needs assessment and workforce development plan, so the state can be really forward thinking in how to address the variety of needs that organizations and providers have. Figuring out the relationship with certification and regulatory authorities. We have heard loud and clear from those that we've already spoken to that it's really important that a Center of Excellence be a trusted partner in the community that providers can go to get the necessary support in making sure that they are doing a good job implementing these practices and that they can go to them for coaching and support and problem solving. We submitted these slides before the announcement around the specialty managed care plan was delivered. So I'd like to just augment this by saying, thinking about the role of the entity, which Anne was describing earlier, in figuring out how a Center of Excellence and the entity can potentially work together to support providers in establishing this network of care. Thinking through the different funding models that a COE may be able to use to be able to leverage all funding that they could be eligible for. And then thinking through some sustainability planning. So does this need to be substantiated in statute? What are the plans for long-term funding? We know that a lot of energy, effort, and resource is going into establishing the children's behavioral health system and undergoing this transformation. We want to be forward thinking to make sure that all of these efforts, including the Center of Excellence, are enduring to make sure that we can continue to sustain those efforts into the future. Next slide. So upcoming opportunities to provide feedback. We would really love to hear from all of you. And so we will be having work group members assembling for a listening session sometime in July. So please stay tuned for more information. We'll be working with Carissa and the Medicaid team to get that scheduled and information disseminated. And then we will be back to talk to the entire group in August during the August 13th meeting to give you updates and share all of the things that we have learned through our stakeholder engagement and discussions with the COEs so that we can give back to you some of our best thinking around this and hopefully gain some feedback from you as well. And with that, Carissa, I think I'll turn it back over to you unless you want to make time for questions.
I mean, if any questions do pop up, we do have one in our chat asking if this is going to be connected to the UNR Center of Excellence on Disabilities. And so just to a note on that, we did reach out to that group so that we could have a conversation. Part of that stakeholder engagement that Dr. Woodard had mentioned. We know that that group exists and that they have had success in building a Center of Excellence. And so they are going to be a key component stakeholder that we can talk to learn about that process. I would say it's a possibility. We don't know exactly what this development is looking like, so we are keeping our options open. And we're just excited to be able to connect with them. And then, so to speak on what Dr. Woodard was just sharing about our future opportunities, we're going to be able to give another update in our August meeting where we'll be able to hear how this research has gone, a bit on what our stakeholder engagement has looked like, and then on our ad hoc listening session, we'll be able to hear some of the feedback from what our working group representatives have shared during that. And then we'll likely have another additional feedback opportunity during that meeting. So if you don't necessarily have questions now, because this is a new topic, we will have that opportunity again to hear where things have gone from here, spend some time digesting this information, and we'll regroup again in August. So I think with that, I just want to say thank you so much to Dr. Woodard and to Rachel for that presentation and for the amazing work that you are doing on this. It is really exciting to know that we're going to have this type of support, or that we're exploring what this would look like for Nevada. Are there any, just looking in the chat, and then are there any other final closing comments that you wanted to share, Dr. Woodard?
Just that I'm very much looking forward to continuing to working with Nevada Medicaid and all of the stakeholders that we're connecting with, and gathering additional information during the ad hoc meeting, and then being able to come back to share what we have learned with this group again in August. Thank you for the opportunity.
Awesome. Okay. So on that note, we're going to move into our wrap-up section of this. We are just at the end of our June CBHT working group meeting. So I want to thank everyone who is still here with us at the end, or anyone who was able to hop on at the beginning and maybe had to hop off before we made it to the end. But we truly appreciate your engagement during these meetings. And I have just a few items for wrap-up for everyone. First, I will just mention that our next CBHT working group meeting will be held on Thursday, August 13th from 4 to 5:30 p.m. and we would love to see you all there. Before we meet in August, we have a few additional opportunities to meet where we've talked about a little bit throughout this meeting, and then this is sort of the compiling of those meetings. So in these different meeting opportunities, you'll be able to provide insight into the different programs and decisions that are bringing us closer to compliance with the DOJ settlement agreement, and more broadly with ensuring that we have adequate access to behavioral health care for youth across Nevada. So as a reminder, our first opportunity is going to be that Clinical Assessment Tool Summit. This is an open meeting where we would invite anyone who is interested to join, to share your feedback and learn about what that process is looking like. As a reminder, we created a participation survey where you can share the dates and times that work best for you. There's a preliminary survey at the end of the participation section, where you can also share if you have experience working with one of the assessment tools. You can share what that experience has been like for you. And so that'll be really helpful for us when it comes to deciding what that assessment tool selection is going to be. That survey is going to close tomorrow, and then from there, we're going to review the results and we will select the time that works best for the majority. So we realize that this means some folks may not be able to join, and if that happens and you would still like the opportunity to provide feedback, please reach out to us directly and we'll schedule a one-on-one meeting where you can share with Dr. Pebbles at that time. And then next, we have two discussions. One of them is on the Center of Excellence. And as a reminder, these ad hoc meetings are closed to our CBHT working group members. So we're going to reach out directly to those folks via email. So the first one, or one of them, will be the Center of Excellence discussion. And then the other one is going to be the continuation on our care coordination series, so to speak, where we will be discussing the role of the child and family teams in discharge planning from PRTFs. And so we had a bit of that initial discussion tonight and we got some really great feedback. So I think that meeting will be another opportunity where we can hear from you more specifically on your thoughts on that. So with that, we will move into our public comment period. If anyone would like to provide public comment, we would kindly remind you that you have 3 minutes to speak. So at this time, do we have anyone wishing to provide public comment?
I would just like to maybe ask maybe I didn't get this in the discussion, but I appreciate the presentation. This is Edward Yoon. I'm from Molina. I just had a question about the measures of success that we were kind of circling around with all these different initiatives and programs that we're about to build. Just to try to understand the direction that we want to go towards. So I think if we can land there, then I think that could help us, or at least at least help me understand, how we're going to approach this.
Yeah, thanks, Edward. I appreciate you being here and happy to take that question. I think there's a lot of data and reporting on metrics that are required by the settlement and are available on our website that may be helpful. I think fundamentally the top line metric that we want to see is decreased use of institutional services, so inpatient ER, residential treatment, and increased use of outpatient services to result in healthier families and children that are able to remain at home and in their communities. So that's really our ultimate goal here. That's both the goal of our settlement and the overall much broader transformation. And I think is our guiding effort around helping train providers in evidence-based practice that they're looking for, strengthening in, as well as our care coordination efforts and all of our enhanced benefits as well. So I hope that's helpful.
You know what? I just want to comment. It is very helpful, and as we know that in the non-behavioral health world, where there has been a similar push to drive outpatient instead of inpatient services, I don't know necessarily we've seen increase in overall outcomes, and so I think it is great that we're checking the box for the settlement. But I was just wondering if we maybe, since we're just starting on this journey, if that maybe that we could hope to actually help overall quality of care for our members, if that was at all possible.
Yeah, I appreciate that. I think we absolutely do not view this as a checkbox activity, nor do we view the settlement or compliance as a checkbox activity. Our goal is to improve what is we recognize in Nevada. We're the worst in the country for kids' behavioral health. It's starting with the institutionalization and increase in outpatient services is the absolute minimum we can do. But of course, the quality of care overall is part of that overall component. So know that that's part of our approach and will continue to be moving forward. So thank you for the comment.
Thank you so much. Do we have any additional public comment?
Marissa, I'm seeing a comment in the chat here that I think is public comment. So I just want to speak to that as well to ensure that folks know that that was seen and appreciated from Brandon about the credentialing process. Want to acknowledge that that can be a quite lengthy one. We are working hard to evaluate and find opportunities for improvement and are working to ensure that the way each of our managed care organizations are doing that as well aligns with state regulatory requirements and our overall goals of making our healthcare system and administrative process easier for our providers. So thank you for the comment. I will note we work hard to ensure that all provider networks are evaluated by an external quality review organization to ensure network adequacy. And there are federal rules that govern how managed care organizations can develop the network. So I know there's a number of ongoing conversations on that piece and happy to spend more time there, but I appreciate your comment and agree that our overall goal is always to connect kids and families with the care they need. And if folks are having trouble with that or have any questions, please do reach out to our managed care inbox, which is managedcare@nvha.nv.gov. So thank you.
Thank you so much, Anne, and thank you for providing that comment in the chat as well. And then I'll just give another minute or two for any additional public comment. Okay. maybe like 10 seconds, not a minute or two, but just hearing no additional public comment. This will be the conclusion of our June CBHT working group meeting. So thank you everyone for joining us. I'll leave this slide up for a few minutes in case anyone needs to grab these links, but it's our website and our listserv and all of the good ways to stay in contact with us. So thank you for being here. We greatly appreciate your input. And we'll see you in August.
Thank you all. Appreciate you being here. And thank you, Carissa, for guiding us through. Look forward to seeing you in a couple months. Take care.
Thank you.
Thank you.